Good day, I am Loren Regina del Monte from BSN2A, and in this video I will be discussing two topics, which are the RH incompatibility and pseudocyesis. Now, let's start with RH incompatibility. So what is RH incompatibility? It is also known as RH factor mismatch. It is a condition that arises when there is a disparity in the RH blood type between a pregnant woman and her developing fetus. The RH factor refers to the presence or absence of a specific protein on the surface of red blood cells. Individuals with this protein are RH positive, while those without it are RH negative. The issue surfaces when an RH negative woman conceives a child with RH positive blood, leading to the potential development of RH disease, a condition that poses a serious risk to the unborn child. So to understand this RH factor, the RH factor is inherited genetically, and its presence or absence is determined by the combination of genes inherited from parents. If both parents are RH positive, the child will be RH positive. And if similarly, if both are RH negative, then the child will also be RH negative. However, complications arise when an RH negative mother is carrying an RH positive fetus. So there is an immunological response. So during pregnancy, especially during childbirth, or if there is any exposure to fetal blood, the RH negative mother's immune system may recognize the RH positive blood as foreign. In response, the immune system produces antibodies against the RH factor, a process known as sensitization. So this initial exposure might not cause immediate issues during the first pregnancy. Still, the problem arises in subsequent pregnancies with RH positive babies, as the maternal antibodies can cross the placenta and attack the red blood cells of the fetus. This immune response can lead to hemolytic anemia, a condition where red blood cells are destroyed faster than the body can replace them. There are also complications and symptoms. RH disease can result in severe complications for the unborn child, including jaundice, anemia, and even neurological damage. These complications can impact the baby's overall health and, in extreme cases, may lead to stillbirth. So there are symptoms of RH incompatibility in the newborn. It includes yellowing of the skin and eyes, which I mentioned earlier, which is the jaundice, and it enlarged spleen and liver, and anemia. These symptoms typically manifest within a few days to weeks after birth. But there are also preventive measures and treatments. So the primary preventive measure of RH incompatibility is the administration of RH immunoglobulin, commonly known as ROGAM. So RH immunoglobulin is typically given to RH negative pregnant women around the 28th week of pregnancy and within 72 hours of childbirth, or any other potential exposure to RH positive blood. So RH immunoglobulin, this works by preventing the RH negative mother's immune system from producing antibodies against RH positive blood cells. Thus, it averts sensitization and subsequent complications in future pregnancies. So in conclusion, RH incompatibility is a complex yet manageable condition that underscores the importance of medical interventions and prenatal care. Through advancements in healthcare, particularly the widespread use of RHLG, also known as RH immunoglobulin, the potential risks associated with RH incompatibility have been significantly mitigated, contributing to improved outcomes for both mothers and their babies. Understanding and addressing RH incompatibility remain integral components of modern obstetric care, ensuring the well-being of pregnancies affected by this condition.
The story of RH disease begins with blood. Everyone on Earth can be divided into one of four major blood groups. But there's another category that differentiates us, RH. Most people have a protein on their red blood cells called the rhesus factor. These people are Rh positive. But a small percentage of the global population is missing this protein, making them Rh negative. These two blood groups are incompatible. That means that if they mix, deadly reactions can occur. That's why it's dangerous when an Rh negative woman becomes pregnant with an Rh positive baby. If the baby's red blood cells get into the mother's bloodstream, her immune system will consider them foreign invaders and create antibodies to destroy them. These antibodies can also cross the placenta and attack the fetus, with terrible consequences like permanent brain damage and even death. This immune reaction begins during a mother's first pregnancy, but is only completed after the baby is born. That's why first babies are typically spared from Rh disease. They're already born by the time the mother's immune system has time to react. But an immune system never forgets, leaving all future Rh positive babies at risk of getting Rh disease. Rh disease was once a major killer, but in the 1960s, scientists discovered a cure by essentially hacking the immune system. With the help of human donors, they obtained the same antibodies that were hurting babies and turned them into a life-saving injection that helps prevent the disease. This injection is given to women before and after delivery, providing an antibody dose that is too small to hurt the baby, but potent enough to prevent the mother's immune system from reacting. It's as though these antibodies help mask the fetus's red blood cells, making them invisible to the mother's immune system.
So that's all for the Rh incompatibility. Now let's proceed to the pseudocyesis. So pseudocyesis. In this topic, we will be having a comprehensive exploration of false pregnancy. Pseudocyesis is commonly known as false pregnancy or phantom pregnancy. It is a captivating and complex psychological phenomenon that manifests when an individual, typically a woman, believes she is pregnant despite the absence of a viable pregnancy. This condition involves a remarkable interplay of psychological, emotional, and physiological factors, contributing to a genuine conviction of being pregnant and often exhibiting physical symptoms associated with pregnancy. So pseudocyesis has psychological and emotional factors. Pseudocyesis is deeply rooted in the psychological and emotional realms, often linked to a profound desire for motherhood, fear of infertility, societal expectations, or an unconscious need for attention and support. The intense longing for pregnancy can trigger a cascade of psychological processes that convince the affected individual of the reality of their pregnancy. So despite any evidence to the contrary, pseudocyesis has symptoms and physical manifestations. So one of the intriguing aspects of pseudocyesis is the manifestation of physical symptoms mimicking those of a genuine pregnancy. This can include missed menstrual periods, abdominal enlargement, breast changes, weight gain, and even the sensation of fetal movement. The body's response to the psychological conviction of pregnancy can be so profound that it induces psychological and physiological changes, further reinforcing the belief in the pseudo-pregnancy. So there are also hormonal influences on it. The mind-body connection in pseudocyesis involves the intricate interplay of hormones. Psychological stress and emotional factors can influence the endocrine system, leading to hormonal changes that mirror those observed in actual pregnancies. Elevated levels of hormones such as prolactin, which is responsible for lactation, and human chorionic gonadotropin, or also known as HCG, a hormone associated with pregnancy, may contribute to the physical symptoms experienced by individuals with pseudocyesis. In diagnosing pseudocyesis, it requires a careful and compassionate approach from healthcare professionals. While there may be a lack of objective physical evidence for pregnancy, healthcare providers must acknowledge the reality of the emotional and psychological experience for the affected individual. Medical evaluations are typically conducted to rule out any other underlying medical conditions that may be contributing to these symptoms. So the psychosocial impact and support of pseudocyesis is that it can have a profound psychosocial impact on individuals experiencing it. And the provision of empathetic support is paramount. Mental health is professionals, including psychologists and psychiatrists, play a crucial role in helping individuals navigate the emotional complexities associated with pseudocyesis. Counseling and therapy can address underlying psychological factors, offering individuals the tools to cope with their emotions and reshape their perceptions of pregnancy and motherhood.
Ever since the marriage, Lisa always wanted to have kids, but it always seemed a distant dream because of the couple's infertility. After a few months, she noticed an interruption of the menstrual cycle. Her belly gradually enlarged, and she even started to feel fetal movements. She was fully convinced that her dream of having children is finally going to be a reality. Everything was going well until the ultrasound scan at the doctor's office revealed that there was no fetus. This is the rare psychiatric disorder pseudocyesis, in which the patient firmly believes she is pregnant and even develops symptoms of pregnancy. Symptoms of this condition include a swollen belly, breast engorgement and milk production, amenorrhea or interruption of the menstrual cycle, the feeling of fetal movements, nausea and vomiting. These symptoms usually last for a few weeks until they visit a doctor to confirm the pregnancy. If the woman doesn't see a doctor, the symptoms can last for 9 months or even years. Though this is common with females, there are case reports of men with pseudocyesis. There's a related disorder in men called Couvade syndrome. In this condition, the husband experiences similar symptoms as the pregnant wife, like morning nausea and backaches. But unlike pseudocyesis, these patients don't believe they are pregnant. So what causes pseudocyesis? The exact cause remains a mystery, but the medical experts think that the mind tricks the body to develop pregnancy symptoms. Let me explain. Many of the women with pseudocyesis have had an intense desire to get pregnant or an intense fear of getting pregnant. The desire for pregnancy could be due to a history of infertility, miscarriages, or a lost child, and most of these women suffer from mild to severe depression. These psychological conditions can cause a deficit in hormones, dopamine and norepinephrine in the brain, and increased activity of the sympathetic nervous system. When the dopamine and norepinephrine levels are low, pituitary hormones like GnRH, LH, FSH, and prolactin are increased due to lack of inhibition. LH and FSH hormones stimulate the ovaries in females. These hormone changes ultimately lead to amenorrhea, or pause of the menstrual cycle. Increased prolactin levels cause breast engorgement and breast milk production. Increased sympathetic system activation can explain the sensation of fetal movements and feelings of labor pains at the expected date of delivery. Chronic contraction of the diaphragm is believed to be the major cause of swelling of the abdomen. The muscle relaxes as soon as the patients realize they are not pregnant, and the abdomen returns to its normal size. The urine HCG pregnancy test will be negative in pseudocyesis. An ultrasound scan will help the doctor to exclude true pregnancy and diagnose this condition. The patient should be educated by gently breaking this bad news. They should be supported by psychological therapy to recover from disappointment.